of Radio Diagnosis in Ain Shams University. Her presentation will be on the updates in diagnosis of cystic fibrosis.
Good afternoon, everyone. My name is Alaa Mostafa, and today I will be presenting updates on the role of chest imaging in cystic fibrosis, a topic that continues to evolve with technology and clinical needs. Let's start with a brief introduction. Cystic fibrosis is a genetic disorder caused by mutations in the CFTR genes. It leads to thick, sticky mucus that affects multiple organs, especially the lungs. The CFTR protein regulates chloride transport. When it malfunctions, mucus builds up, causing chronic infection and inflammations that damage lung tissue over time. There are many signs and symptoms of cystic fibrosis. Some are related to respiratory system when the mucus clogs block airways. They are ongoing chronic coughing, shortness of breath, wheezing, frequent sinus infections, frequent lung infections, clumping or enlargement of the fingertips and toes. Since lung disease is the leading cause of morbidity and mortality in cystic fibrosis, early detection and continuous monitoring are essential for improving outcomes. Imaging helps us detect structural changes, monitor progression, guide treatment, and evaluate transplant readiness. It's a cornerstone of cystic fibrosis management. We will explore three main imaging modalities: chest radiography, computed tomography, and MRI, each with unique strengths and limitations in cystic fibrosis care, as well as new emerging technologies. Imaging challenges in cystic fibrosis include radiation exposure, variability in interpretation, and the need for pediatric-friendly protocols. Standardized scoring systems help address these issues. First, we will discuss chest radiography. Chest X-rays are widely used due to their accessibility, low cost. They are typically used for routine monitoring and acute exacerbation. Common radiographic findings include hyperinflation, peribronchial thickening, bronchiectasis, atelectasis, and consolidation. Here is a case example showing chest radiography for monitoring of disease progression in two patients with cystic fibrosis. A image is a coronal chest radiography in a 9-year-old girl, shows mild right upper lobe bronchiectasis as marked by the yellow arrow. B image is a coronal chest radiography in the same patient 10 years later, shows increased upper lobe cystic bronchiectasis as marked by the solid arrow, with nodular opacities as marked by the dashed arrow representing mucus plugging. C image is a coronal chest radiography in a 1-year-old girl, was interpreted as normal. D image is a coronal chest radiography in the same patient 10 years later, shows new upper lobe predominant bronchiectasis as marked by solid arrow and airspace opacity as marked by dashed arrow. Now, we will talk about the new quantitative scoring system for chest radiography in the evaluation of cystic fibrosis. The Norsen score. Norsen score quantifies radiographic abnormalities in cystic fibrosis. It's useful for tracking disease severity over time. It depends on dividing the lung into 4 zones: upper and lower right lobes, upper and lower left lobes. For each zone is based on overall linear markings and nodular cystic lesion. 0 is normal, 1 is mild, 2 is moderate, 3 is severe, and 4 is very severe. Crispin normal score. This score also depends on dividing the lung into 4 zones: upper and lower right lobes, upper and lower left lobes. It evaluates overinflation and linear markings. It's semi-quantitative and helps standardized interpretation. Bracefield score. It's designed for pediatric patients. The Bracefield score assesses 5 radiological features: air trapping, linear markings, nodular cystic lesions, and large lesion. Higher scores indicates better lung health. Wisconsin score. This system combines elements from other scores and correlates well with clinical outcomes. It's used in both research and practice. Advantage versus limitation of radiography. Radiography is quick, inexpensive, and low in radiation. It's ideal for frequent monitoring, especially in resource-limited settings. However, it lacks sensitivity for early disease and has high inter-observer variability. It's best used alongside with other modalities. Despite its limitation, radiography remains a valuable tool. It's often the first imaging step and helps guide further evaluation. In summary, chest radiography is useful for routine monitoring. Scoring systems improve consistency, but not ideal for detecting subtle or early changes in cystic fibrosis lungs. Now, we will discuss computed tomography role. CT is a gold standard for assessing structural lung damage in cystic fibrosis. It provides high-resolution images of airways and parenchyma. Key CT findings in cystic fibrosis involve bronchiectasis, mucus plugging, air trapping, and consolidation. Here is a case example showing CT monitoring of disease progression in a 2 patient with cystic fibrosis. A image is axial image in a 9-year-old girl, shows minimal bronchial wall thickening as marked by the yellow arrow. P image is axial image in the same patient in 10 years later, shows marked progression of bronchiectasis as marked by solid arrow and bronchial thickening as marked by dashed arrow with new centrilobular nodules as marked by the arrowhead. C image is axial image in a 1-year-old girl, show mild streaky opacities and atelectasis as marked by the arrow that was not detected in chest radiography. D image is axial image in the same patient 10 years later, show new right upper lobe cylindrical bronchiectasis as marked by the solid arrow and bronchial thickening as marked by the dashed arrow with tubular opacity as marked by the arrowhead, representing mucus plugging. Now, we will talk about the new quantitative scoring system by CT in the evaluation of cystic fibrosis. PRODI2 score. This scoring system evaluates the extent and severity of lung damage. It's widely used in clinical and research settings. The CFCT score is standardized CT interpretation and is particularly useful in clinical trial and longitudinal studies. Bragma cystic fibrosis score, which is a simplified CFCT scoring. Thin section CT images are divided into geometric grids and annotated for abnormalities. Scores are derived from the total volume of the lung containing each weight finding. Although sensitive, this method remains very time-consuming to train readers and for each CT examination. Its quantitative scoring system measures percentage of lung affected, useful for tracking disease progression. CT involves higher radiation exposure, especially concerning in children. Low-dose protocols are increasingly used to mitigate this risk. CT is essential for evaluating transplant candidates. It helps identify complications and assess the extent of structural damage. Pre-transplant imaging assesses lung damage, and post-transplant scan detect the complication and monitor graft health. In summary, CT is the most sensitive modality for structural changes. A scoring system improves objectivity, but radiation exposure must be managed. Now, we will talk about the MRI role in cystic fibrosis. MRI offers radiation-free imaging and can assess both structure and function. It's gaining popularity, especially in pediatric cystic fibrosis care. VEPS MRI combines ventilation, inflammation, perfusion, and structure into one scan. It provides a comprehensive view of lung health. Techniques like hyperpolarized gas and oxygen-enhanced MRI allow us to assess ventilation and perfusion directly without radiation. Here is a case example showing MRI for monitoring of disease progression in 13-year-old boy with cystic fibrosis. Axial post-contrast VIBE-MR images show upper lobe predominant bronchiectasis as marked by the solid arrow and peribronchial thickening as marked by the dashed arrow with area of mucus plugging as marked by the arrowhead. MRI versus CT. CT offers superior structural detail, while MRI is superior in the functional imaging. Together, they provide a complete picture of cystic fibrosis lung disease. MRI has longer scan times and limited availability. It also requires patient cooperation, which can be very challenging in younger children. MRI is ideal for children due to its safety profile. It's useful for early detection and repeated imaging without radiation concerns. New MRI sequences are faster and more detailed. AI-assisted interpretation is also improving diagnostic accuracy. Now, we will talk about the role of AI in imaging of cystic fibrosis. AI can automate scoring, recognize patterns, and predict outcomes. It's transforming how we interpret cystic fibrosis imaging. Machine learning helps segment images, track progression, and integrate imaging with clinical data for personalized care. Biomarkers like mucus burden and airway wall thickening are being quantified. These offer new insights into disease severity. Combining imaging with spirometry and genetics enables personalized treatment plans and better outcome prediction. Future imaging will be multimodal, real-time, and remotely accessible. These innovations promise earlier detection and better care. Early imaging in children helps detect structural changes before symptoms worsen. Tailored protocol minimize radiation exposure. To summarize, radiography is best for routine monitoring, CT for detailed structure assessment, and MRI for functional imaging. AI, machine learning, and quantitative scoring are revolutionizing CT fibrosis imaging. These tools enhance precision and personalization. Imaging will continue to evolve. Integration with clinical data will enable earlier detection, better monitoring, and improved outcomes. Thanks again for joining me today. If you'd like to connect or discuss further, feel free to reach out. Thank you.
Thank you, Dr. Alaa Mostafa. We are going to present now the updates in diagnosis of cyst